As many of you know that we have a quite long tradition in treating infections one-staged, but also, of course, we are open for new approaches. And in addition, we have focused also with my chief, Thorsten Gerke, on this consensus meeting that Carlo has just introduced to you. I think there's also been some very nice support from Spain for this consensus meeting, and this subject for this session right now that we want to discuss in the group together with Dr. Ribas and Dr. Flores is how can we identify risk factors for infection and how to prevent them. And I think Carlo gave a good introduction of what might be one good solution surgical-wise. The question is, how are we able to identify patients at risk, maybe even earlier, to optimize them before we operate them? So not necessarily orthopedic work, it's rather work for maybe general practitioners, but we as orthopedics, we have to identify those patients, of course. So we heard this before, and the background everybody is aware of. Some people say, or some hospitals say they have an infection rate of 0.2%. Some say it's 3 to 4%. I believe it's probably the truth is somewhere in between. However, I don't believe there's anybody who says he has no infections, of course. As we know in our species, orthopedic background, especially in total joints, we have most often gram-positive strains that affect our infections. And the question, as mentioned before, what are possible risk factors, and how are we able to lower the risk of periprosthetic joint infection? So there have been, of course, some very good papers in the past, and we know that the Americans are very strong in this and have been measuring this, the Academy especially measuring different pathways and describing definitions, which have been very useful in the past, and they did a lot of good work, which we also used for the consensus meeting last year. And many of you know the name Jay Parvizi, and his group and others in North America have spent a lot of time in identifying risk factors. And basically, if you look at the stratification, it's basically patient factors, which belong to the patient's preoperative. It's surgical factors that we as a surgeon cannot affect, and postoperative factors. And I think on this session, we want to focus on the preoperative patient factors maybe most times. And you see here in North America, of course, they have different identities of infections maybe than we have in Northern Europe. But you see here in this paper, they found out at the Rothman Institute what their major risk factor was. For instance, Hispanic, a higher ASA score, a higher body mass index. And of course, those are a lot of logical factors. The problem is always, can you put some numbers behind it to make sure or to really clarify scientifically what are really relevant factors. And I'm trying to show you some of those that might be relevant for your daily practice. So this has been the first work group in Philadelphia last year. And again, there's been tremendous work done by faculty all over the world, from Italy, from Spain, North America, South America, and we put together some quite good work. And the very first group was mitigation and education, so taking care about the prevention of infection, basically, which is the really start before you operate, of course. And all that information that was gathered was based either on all available literature that we have been worked on, or otherwise on expert opinion, depending on what literature was available. And one of the very first questions we were trying to answer, what are relevant or significant risk factors after total joint arthroplasty? And as everybody knows, if there's a patient with previous history of septic arthritis, of course, he's under relevant risk for developing infection afterwards. So, of course, it's very logical. However, we know we have to really take care about this. And you see here, almost everybody in the room agreed on this fact. And the question, again, was not only to define the general factors, also specifically, and you see a lot of those here, diabetes, malnutrition, and I'm showing you some numbers behind this right now, not to mention all of those. And one of the major risk factors that has been really identified was the history of previous surgery. So local wound area, you have to really make sure and look at the wound, have the patient undressed before you operate, have the residents look at it the day before surgery. And we see this quite often also in the endo clinic, that the resident calls you during the day when he sees the patient right the day before surgery. We don't do day surgery in endo clinic, but you see really sometimes different problems at the local wound area, and there's been good and relevant publications that if you have a history of previous surgery with local wound area problems, you should probably not operate this on a total joint because it's elective surgery. So you really have to do a proper infection workup before you really start the operation. Optimally, of course, the day before or a couple of days before you operate. One big other point, and I think this takes into account not only North America, but we also know in Germany, maybe also in Spain, Italy, other countries, that diabetes is an increasing problem. And there have been a lot of multiple meta-analyses showing that if the patient before operation has a fasting glucose above 180 milligrams per deciliter, he's at very high risk for postoperative infection of the total joint. This is for the knee and of course for the hip as well. And of course, you have to measure the HbA1 level. If it's above 7% for a longer period of time, the patient is really at high risk. So we really want to know what those patients are facing before the operation. So optimally, and I think really optimally, you should send those patients away for the general practitioner to optimize their diabetes before you operate. And this has to be done, of course, not only 1 or 2 days, because you know the HbA1 level above 7%, it takes usually weeks to increase or make this value a better one. And again, also, there has been good incidence or good literature about postoperative glucose. So really take under consideration, this is a higher rate of surgical infection if your patient is under constant higher glucose after the operation. So you really should take care, and optimally, if you have a big hospital or do it on your own, you should measure those regularly in case they are not optimally approached with medications even after the operation. Malnutrition. I think malnutrition may be not a big problem in most of the Western European countries, maybe a little bit more in North America, I'm not sure. But we know malnutrition is associated, and this is based on the literature, this is evident, it's associated with poor wound healing, longer hospital stay, and of course, which is really relevant for also our friends in North America, is a persistent wound drainage, which usually takes into account a longer stay in the hospital. In Germany, usually patients stay in the hospital 6 to 7 days after a primary operation. I know this might be different in many countries. So you really want to measure the following: albumin, transferrin, and prealbumin. And the possible treatments you might take into account are high protein nutrition, vitamins, and mineral supplementation. And again, this sounds very theoretical, but you have to keep in mind this is a very elective operation, and you want to make sure your patients enter this operation in an optimal setup. And again, this is probably not the work that you do in your practice, in your daily practice. This has to be done by the patient and usually in combination with a general practitioner or house doctor. This is in Germany, and to be very true, in Germany also we have the problems because the house doctors sometimes say, I don't care. So we have sometimes problems, and we can discuss this later. So because the orthopedic surgeon recommends something to the general practitioner, and sometimes they say, yes, I can do this, but not in the next week. So it takes sometimes even half a year until they react. So you have to really talk to your patients and make sure the patients get an understanding why this is so important. Another factor, and this has been discussed in the literature very critically, and also in our clinic very critically in the last few years, obesity. Why is obesity a high risk factor? Of course, of risk for wound healing problems and periprosthetic infections. What are the reasons? It's not because they're only obese, because you don't like to operate that much, because the background is, it's the rationale, it's usually longer operative time you need for those patients. It's a diabetes which is associated with the obesity, and those patients are under higher risk for allergenic blood transfusion, and we know blood transfusion in addition is a high risk for periprosthetic infection. So the critical BMI that has been identified in the literature before our consensus meeting, based on all available literature, was BMI higher 40. So, and one critical point we also have to talk about in our discussion later, we want to talk about the antibiotic prophylaxis. You have to keep in mind that one single shot cephalosporin or third generation cephalosporin is different from 1.5 grams in an 80 kilogram patient than a 160 kilogram patient. So you have to keep in mind and talk to your anesthesiologist about the doses adjustment. So BMI 40 really seems to be a critical BMI if you look at the literature talking about infection, and you should make up your own mind. This is a USA patient. I used to show this picture from Jay Parvizi. So to be very honest, I usually say, Jay, this was your last patient you operated on. Of course, this patient is under significant risk for infection. If you ask myself and maybe the endo clinic, we would say maybe we can postpone the surgery. Sometimes those patients, as you know from your own practice, are very pushy and they come back after 1 year, another week, and of course sometimes the nutrition and all surgical interventions for obesity don't help. And I know some people really say after a couple of years, okay, now I'll operate you. But keep in mind that those patients are really under high risk. When I arrived and started my career at the endo clinic as a fellow in 2009, we had a big, strong rule. Our maximum accepted BMI was 35 back then. This has been cancelled, to tell you the truth. And nowadays, the average BMI in our clinic this year has been 30. So this is really interesting. So you think over the years, the indications are getting, I would say, weaker and weaker, and maybe you have the same experience in your clinic, maybe. But we can also discuss it later. Smoking. Is smoking a real risk factor? Yes, it is. There have been, by the year 2013, before we looked at the literature for our meeting, there has been 6 randomized trials that have been shown stopping smoking helps. Of course, usually, as also from my own experience, you never have a smoker stopping the whole period, but you can stop having him smoking a couple weeks before the operation. That really helps. And you really see a heavy tobacco users, it's 1 package per day, more than 1 package per day, has really a significantly higher risk for complications. So if you are able to reduce the smoking already a couple of weeks before the operation, this will increase the wound healing and thus decrease the incidence of PGI. I know this has been a talk in Turkey. I know smoking in Spain looks different, but this has been a Turkey smoking style here. As you've seen here, I'm not sure about the smoking. Another big issue that has been associated with malnutrition and sometimes diabetes is, of course, alcohol consumption. And again, there's been good evidence that if you are facing a patient with excessive alcohol use, which means larger than 40 units per week, 1 unit is usually half a bottle of vodka, just to let you know what it is, increased risk of morbidity and increased risk of infection. And so the recommendation that have been found in the literature says you should have at least 4 weeks of abstinence if possible. So if you have a really high-end alcohol consumer which cannot stop his consume before the operation, you should really think of postponing his surgery to prevent morbidity and infection. Further risk factors, which are all associated, and I don't want to go into detail, of course, obviously active renal disease due to hemodialysis and decreased nutrition and sometimes immunostatus of those patients, active liver disease, hepatitis, cirrhosis, immunosuppression, of course, IV drug abuse, HIV. And there has been some tendency in the literature, however, without significance, that male are at higher risk for infection than female. I don't know why. And post-traumatic for obvious reasons, and especially if there has been some implants or any metal in this joint before. Another big question, always been trying to answer it, and we try to answer it, also by expert opinion. Should all patients be screened for oral problems hygienic problems, yes, they should be screened, not necessarily by a dentist. If you ask them actively and you can really rule out severe problems by yourself, by the resident or even yourself, or a questionnaire, it should be enough. You don't need to send everybody preoperatively to a dentist. Anyways, nobody will pay for it. So, but as you see here, agreement was 80%. Dental disease is still controversial regarding its risk, especially if you talk about after the joint replacement. And there have been some papers which have been shown that the use of antibiotics as by the Academy recommendations have changed from 2003 to 2009. If your arthroplasty is done in the first 2 years and you have a high dental risk procedure, you should take some antibiotics. If you have a low risk dental procedure like a normal cleaning or prophylaxis, it might not be necessary. Another big question, what should you do for MSSA patients? Do you need to screen everybody? As we know, some countries do this. We know our friends in the Netherlands and Holland, they screen every patient. Is it really necessary? We don't believe so. Although, of course, it makes sense in high-risk patients. So you don't need to screen everybody, but high-risk patients really makes sense. What is the incidence and prevalence of Staph aureus within our patients, within us, within our residents? You see interesting publication here, and you see here that basically MSSA sensitive seems to be a problem in the attending surgeons, although 23% seems to have them, or while MRSA is only available or prevalent in 2.7% of us. It seems to be different for the patients. You see here almost the same as the patients have. Of course, this has been a nice prospective controlled study, but you see here what problems might arise if you look at your own possible contamination. How should you treat those patients? And of course, as short as you know, many countries have adopted this. You can use octinisept, or as many countries still use, mupirocin is the most accepted current treatment method of choice for decolonization. And I can also tell you that mupirocin has a very useful usage to reduce MRSA in the nose. However, there's a new paper coming out very shortly from the Rothman Institute that's been able to show even if you eradicate your patients, it usually comes back in 70% after 1 year after you control. So you have to keep in mind, you should eradicate them before the operation. However, it doesn't mean it's not coming back, just to keep you in mind. Should all healthcare workers be screened for MRSA? So should we all be screened here sitting? No, routine screening is not necessary for all of us. And this also has been based on the literature that has been found. Of course, if you have symptoms and any problems, you should be. Another question also in Germany asked, and I know also in the effort has been a big questionnaire about this, and there's also some controversial data existing. Should all patients be screened for routine urine analysis before the operation? It should not be based on the factors that we found back before our consensus meeting. But of course, if you have patients with symptoms, you should really screen them and maybe administer antibiotic prophylaxis before the operation. The main paper we found before our meeting was this one, where they found really a high, from HSS basically, where they found a low correlation between urinary tract infection and PGI. But I know there have been some recent papers coming out from Europe that showed the opposite. So maybe if we reevaluate the literature in a couple years or months, maybe we find different values within the next years. However, this paper was quite interesting because they were able to include a high number of patients, as you see here. So keep this in mind. Maybe one of the last questions to end this talk, should disease-modifying agents be stopped? Yes, and as you know, a lot of patients, especially rheumatoid arthritic patients, are under disease-modifying agents, and we says yes, we should stop them. In Germany, the actual recommendation, for instance, for MTX is not to stop it by the rheumatologist. However, in the consensus meeting, we said you should stop it, however, only at day of surgery, not before. And you see here a lot of those modern infliximab, rituximab, and all those very severe immune disease, medications should be stopped. A proper time before the surgery. Which host factors, maybe the very last factor now, is which host factors might be associated with possible fungal infections. You know, fungal infections are very rare. You don't find them very easy. So what host factors are associated? And of course, as logical, those are always, those have been the same ones what we found for general risk factors. And we were looking at the literature back then. We found 46 cases of fungal infections in the whole literature in the world. And you see here what main problems they had, what additional disease they found. And you see, most interesting, of course, diabetes, but I would say, please have a look at this. Most of them had a prior infection with prolonged antibiotic therapy. So basically, it's a house-made problem. Usually, you should look at your own germs and maybe antibiotics you used, because they might cause the following fungal infections. Hair removal, is it necessary? I think some countries have more incidence and prevalence of hairy environment, especially in men. Hair removal is necessary, we recommend it. However, nowadays you should use clippers instead of shavers, because the abrasion itself maybe becomes sites of bacterial growth. So the hair removal should be as close as to the operation. So we recommend it to do this in the pre-op room. However, in the endoclinic, to be very realistic, we do it on the ward before the patient is entering the OR for logistic reasons. So take-home message, shaving is out. Intact skin, and of course everybody is aware of, you should be very careful operating on patients with ulcera or other eczema or psoriasis lesions, and really keep in mind arthroplasty is elective surgery. Consequently, in general, we know there's no need for any risk of PGI. The evidence for many potential risk factors is really, really clear. And maybe the most important, as Carlo mentioned, factor is preoperative and intraoperative prevention of infection instead of only treating it afterwards. And I want to thank you with this picture from Hamburg City. Thank you very much.